Okay, we've got a 59-year-old male who is in the ICU. He had a median sternotomy approach done and had a aortic valve replacement completed yesterday. He has not been out of bed, and we were to do an evaluation on him today. Some surgical precautions that I have with this patient: since he did have a median sternotomy approach done, I want to make sure that he does not have any kind of traction forces or any kind of push-pull forces going across his chest. Whenever we do any kind of movement, I want to make sure that he does not flex or abduct his shoulder greater than 90 degrees. So whenever we get out of bed, if we do, I want to make sure that we do a log roll and don't do any kind of pulling on the bed rails or pushing up really hard from the bed. So as the therapist, we will help him sit up at the edge of the bed. Also want to make sure that he does cough with his pillow. Whenever he does need to cough or sneeze, he needs to hold that close to his chest and decrease the forces that's going across his sternum there, and make sure that he does not drive because of any of the medicines that he's taken, such as the Norco and the morphine, and avoid airbags for about 4 to 6 weeks. I want to also make sure that he uses his incentive spirometer to increase deep breathing in this patient. Make sure that he does not try to hold his breath whenever we work with him or do his treatment. Do I have any contraindications to physical therapy? I don't think I have any contraindications, but I do have some concerns because of some of his lab values. As for his lab values, his white blood cell count is a little elevated. It was at 11.2. This could be because of simply just having surgery, but it could also be a sign of infection. And his platelet count is trending downwards, but it's still in the normal range, but we want to continue to monitor that. That could also be a sign of infection, and I want to make sure that I'll check with the patient, make sure they're not feeling fatigued or they're feeling dizzy or lethargic or they have a fever. I do know from looking at the vitals that the patient is not running a fever right now, so that's good. I want to just keep monitoring that. The patient is on antibiotics. They are on ceftriaxone, so hopefully that continues to work and the patient does not get any kind of infection. The patient's hematocrit and hemoglobin is both trending down, so that is a concern to me. This could decrease my patient's activity tolerance or their endurance. The hematocrit being down could also cause a patient to have chest pain or shortness of breath, a headache, be very diaphragmatic, or have clammy skin, and again have that impaired endurance. I know that their hemoglobin is at a 7.8, which is not in the critical range, but it is still slowly trending downward, but very slowly. And their hematocrit is very slowly, again, trending down, but it's at 28%, but it's not in critical range. Their INR is trending upwards. It is at 1.8 right now. I want to try to get that patient's INR at about a 2.5 to 3.5, which is the therapeutic range for this procedure done. And also the patient is on warfarin and Plavix. So hopefully, since these labs were last drawn at 5 a.m., hopefully by now this patient's labs are looking a little bit better and their INR is even higher than the 1.8. I know that even a 2.0 is the therapeutic range for DVT and PEs and things like that. So I want to make sure that this patient's levels are getting better. Would I treat this patient? I would like to check with the nurse and see if they were planning on doing any kind of blood transfusion, since my patient's levels of their hemoglobin and their hematocrit was low, and see if when they were planning on drawing their next set of labs. If they were planning on drawing them soon, I would wait. If not, I would just proceed really cautiously with this patient. Their vital signs are looking really good compared to what they were. Their heart rate is at 80 right now. It was at 1 a.m. this morning, it was at a 127, so it's been progressively getting better. Their blood pressure is also getting much better. It was a 96/68, but it's now at 100/78. I want to be cautious because this patient does have a history of hypertension, and I need to watch out for orthostatic hypotension with this patient, because even though it's not super low, if they're used to having a really high blood pressure, this could still cause them to have that orthostatic hypotension, and I need to watch for dizziness or things like that. Their oxygen is really good right now. It's at 98%. It was floating around in the low 90s, but it has progressively gotten better. Their respiratory rate's also gotten better. It's at 11, where it was at like 20 early this morning. Their temperature, again, they did not have a fever, but it was up at 99.9, so it was getting close to that mark. But again, it has slowly decreasing. It's now at 98.8. Their pain is really good. It's at a 5 out of 10 right now. Again, it was a 9 out of 10 this morning, and it has progressively gotten better. They are taking Norco and morphine, and they are given these PRN. One is every 2 hours, one is every 4 hours. If their pain is elevated, we can ask the nurse if they can give them some medicine before we treat this patient to see if that will help with their pain level. They ask for their lines, tubes, and equipment. This patient does have an EKG monitor. I want to monitor their heart rate and look for any kind of arrhythmias with this patient. They've got a blood pressure cuff on their left lower extremity. Again, I want to monitor their blood pressure and look for any kind of orthostatic hypotension and see if they have any symptoms of that. They do have a pulse ox on and they're wearing oxygen. I want to monitor my patient's oxygen level and make sure they're getting good perfusion to and oxygen to their muscles. They do have a peripheral IV in their brachial artery on their left and an arterial line in their right radial artery. I can check with the nurse about seeing about disconnecting that arterial line if possible. I want to make sure that with the arterial line, specifically in that right radial artery, I need to make sure that there's no kind of clamping or kinking in the line. And if possible, I would like to use a cardiac walker with this patient so they don't put a lot of pressure down on their hands, but they can put more of their pressure on their forearms when they walk. And this would also be better for them because it would help, especially if they have a lower endurance level, it will help them with walking. And I have probably a little bit more room to put some of my tubes and lines on with that cardiac walker. They do have a Foley catheter. If it is full, I can empty it before we walk this patient or do whatever kind of intervention we do with this patient. I want to make sure that we do measure, if I empty it versus the nurse, make sure I measure the cc's and let the nurse know, and always keep the Foley catheter below the insertion area. And this patient has a chest tube where they also have a water seal on this. It does have that passive drainage into that chest tube, so we can move with this patient or ambulate if tolerated by the patient. I want to look for the drainage, look for any kind of bubbles, and make sure that I don't mix it up or knock it over to where I get where I mix the stuff up inside to where it would make a false reading on the drainage. And again, make sure I keep it below the insertion site. Again, I want to make sure I assess all of my lines and my insertions. I want to make sure that I don't have any kind of signs of infection from any tubes. I want to look for oozing from the IVs or reddening, or look for how well they're taped down and look for any kind of backflow. I don't have any kind of preclusions for PT. I can see about getting that arterial line disconnected from my patient. If we do, I want to make sure that we have a Dynamap close if we do go further away from the bed. That way we can still check their blood pressure when needed. As for exams on assessment, I want to do a lung auscultation on this patient since they did have anesthesia and they are more likely to have that atelectasis in their lungs. And I want to encourage my patient to use their incentive spirometer. And then I also want to check their vitals specifically for orthostatic hypotension because I want to make sure that this patient is getting adequate perfusion and oxygen to their muscles of respiration and their heart and the rest of their muscles. Thank you.